Hello everyone and welcome to this new lecture. Today we will talk about non-infective stomatitis. This condition can be caused by autoimmune and immune-mediated diseases. The most of these non-infective stomatitis have an unclear cause, even nowadays. But there are some theories that explain the etiology of such diseases in order to encounter and plan an appropriate treatment. These theories and supposed studies are not complete, but they explain how to encounter and treat these non-infective stomatitis. We will classify these non-infective stomatitis into some classifications in order to make their studying and diagnosis easier. First classification is the ulcerations without preceding vascularizations, one of which is called the Paget's disease. That's an ulceration without preceding vascularizations. Vesiculation or vesiculation. This is an infection ulceration without preceding vesiculation. This disease was originally defined as a triad of ophthalmic, genital ulcerations, and uveitis. So it's infection of the mouth, genitalia, and eyes. But it is well known as a multisystemic disorder and has a varied manifestations, all of these disorders and manifestations are called the Paget disease. This disease is relatively common in the Mediterranean Sea area, that countries bordering the Mediterranean Sea, and very common in Japan. The Paget disease is a systemic vasculitis. It's not preceded by any vesiculation. It's the classification of this disease, not preceded by any vesiculation, but it is known as a systemic vesicularis, characterized by hyperactivity of neutrophils with enhanced chemotaxis and elevated pro-inflammatory cytokines like IL-8, IL-17, TNF-alpha also increase. And TNF-alpha play a major role in the pathogenesis. So first of all, neutrophils increase, chemotaxis increase, and pro-inflammatory cytokines also increase with the TNF-alpha that plays a major role in this disease. The general patients are adults, male between 20 and 40 years old, and the oral mucosa is the common site of infection with an aphthous ulcer. Second most commonly involved site is the genitalia, and the genitalia presents with an ulcer of the scrotum and penis in males, or ulcers in the labia in the females. When it comes to the eye, so we said it's a mouth, genitalia, and eye infection, but when it comes to eye, it can lead to blindness and represented with uveitis, retinal vasculitis, and vascular occlusion, optic atrophy, and conjunctivitis. Blindness, as I said, it's very common in this disease, and the periodic examination and evaluation by an ophthalmologist is necessary to prevent blindness and development of eye problem associated with the Paget's disease. The skin lesion resembles erythema nodosum and pustular lesions. Erythema nodosum and pustular lesions that occur in over 50% of patients with Paget disease cases. As we said before, it's not limited to the mouth, genitalia, and eye, but it can also affect the nervous system, the skin, as we see in this picture, in more than 50% of cases. Even arthritis can occur in 40% of patients with Paget disease, affecting the knees, ankles, wrists, and elbows. Even in some patients, as I mentioned, the central nervous system can be affected and be the major distressing component of this disease. Central nervous system could involve cranial nerves and brainstem syndrome. or a neurological degeneration resembling multiple sclerosis. Other types and other places and sites of affection include the thrombophlebitis, that's problem with the veins and thrombosis, the blood, intestinal ulcerations, venous thrombosis, and renal, cardiac, and pulmonary disease could also be manifested with Behçet's disease. Oral aphthous is not distinguishable from other regular FA, but they are persistent and occur more than 3 times per year, and they are the most common consistently found feature in above 98%, and it's frequently the first manifestation of the Behçet's disease, and it's considered a differential diagnosis for it, especially with people that suffering from aphthous stomatitis and in the same time are in a vulnerable racial group and have a medical history suggesting a Behçet disease inclination. Special tests like a blood test and these types are not helpful except for pathology tests, and the pathology test is inserting a sterile needle in the skin, sterile needle of 22 to 20 gauge, usually on the forearm, in order to check for a papule or pustule that's formed after 24 to 48 hours. This is a pustule or papule. The pathology test does not always indicate there is a Behçet disease, nor does it indicate the severity of the disease. Also, it can indicate some other types of diseases, pathology tests. Even though this is not specific and does not indicate the severity of the Behçet disease, it is still required and considered to be an important diagnosis to avoid the life-threatening nature of thrombosis and the risk of blindness or brain damage. So we have blindness, brain damage, thrombosis with Behçet disease that could be avoided by using the pathology tests diagnosis. Now we can give, of course, some points for these pathology tests. If we gather more than 4 points, that means there is a Behçet disease, there is a possibility of Behçet disease. If it's less, there is a less strong suggestion or there is a weaker suggestion of the Behçet disease. Pathology test will give it 1 point. Oral aphthous, ocular problems, genitalia problems or lesions will give it 2 points. While skin neurologic vascular manifestation will give it 1 point, just like the pathology test. Treating now, how to treat the Behçet disease? It's of course not as simple as you might expect, because Behçet disease, including many manifestations, we would have to treat each case individually. Like oral aphthous will give immunosuppressive medications like corticosteroids, azathioprine, pentoxifylline, thalidomide, colchicine, or combination of the mentioned drugs. That is when there is a severe case of aphthous and reoccurrence of aphthous stomatitis, or even a major FA is present. Therefore, we should give it these systemic medications to suppress the immunity. Other than Behçet disease, now we will talk about the lichenoid reaction. It is a family of lesions that are having different etiologies, but with a common clinical and histologic appearance. But neither those clinical or histological features will enable us to discriminate between different types of lichenoid reactions. But these diagnoses will help us to distinguish lichenoid reactions from other pathological conditions of oral mucosa. So we know that this one is a lichen planus reaction, or lichen reaction, not lichen planus, lichen reaction, lichenoid reaction, or some kind of another disease. There are, of course, as we mentioned before, many types of lichenoid reactions, including oral lichen planus, lichenoid reaction, contact reactions, and lichenoid drug eruptions, and lichenoid reactions of a graft versus host disease, GVHD. Starting with oral lichen planus. planus. There is a common inflammatory disease of the skin and mucous membrane. Mainly affects people with a middle age or over, with a characteristic appearance and distribution that is well known. But the etiology of this oral lichen planus is unknown, but there has been support or evidence that the immune system has a primary role in the development of such disease, and that evidence is supported by the histopathological characteristics of subepithelial band-formed infiltrate dominated by the T lymphocytes and macrophages, and even the degeneration of the basal cells. The degeneration of the basal cells is known as liquefaction degeneration. Females are the most commonly affected, with 65% predilection of patients. Unlike the Behçet disease that we have studied before, there were male between 20 and 40, but this time it's females for more than 40 years of age. If the lichen planus is untreated, it can continue for 10 or more years. A lesion can occur in a combination or in isolation of reticular, lag, shape, erythematous, atrophic, or erosion type. Starting with a reticular type of oral lichen planus, that is the most common form of oral lichen planus, consisting of slightly elevated fine whitish lines called Wickham's stria, and these Wickham's stria can also be circular in a circular patterns. They can be not palpable, they cannot be touched sometimes, and can even sometimes be firmer than the surrounding mucus. Another type is called the atrophic or erythematous type. This one is red areas, mucosal thinning and combined with stria, just like the previous one, but different in color. This one is reticular form, erythematous form, another erythematous form. Erosion is irregular epithelial destruction. Erosion is another type, and slightly raised yellowish margins, but with different shape and depressions, and it looks like an erosion type lesion. Another type of oral lichen planus is the plaque form of popular type, and this one occurs with the initial stage of the oral lichen planus on the dorsum of the tongue, and sometimes it persists with the disease as it affects mainly the buccal mucosa. So if it occurs initially, it affects the dorsum of the tongue, and if it occurs later, it will affect the buccal mucosa papula form. This one is the erosion type, and this is the plaque affecting the buccal mucosa with the persisting disease, and this one affecting the dorsum of the tongue, occurring with initial disease of oral lichen planus. Common sites include buccal mucosa, dorsum of the tongue, gingiva, but the gingiva is not, the lesion is not usually confined only to the gingiva, so it's occurring in many other places of the oral mucosa. And even so, it has to be confirmed with a biopsy. The lesion is bilateral and symmetrical most of the time. These symptoms usually do not occur in the skin, although it's considered a skin disease, but only 15% of patients encounter with oral lichen planus have cutaneous or skin lesions. When it occurs in the skin, there is a purplish papules, typically on the forearm, wrists, but even if we see such conditions, that's not a confirmatory diagnosis of oral lichen planus. These patients usually scratch and damage, causing trauma to the region, because this will give them some kind of a relief, as you can see in this picture. This is Koebner syndrome or Koebner phenomena when they scratch their lichen planus on the skin. Most frequently occurring, if it is extraorally, it occurs on the genitalia with 20% of that. Women present with oral lichen planus, as we said before, women are more affected than men with oral lichen planus. Genital mucosa causing, if it affects genital mucosa, it will cause burning, pain, vaginal discharge. This dyspareunia, this one is generally encountered with erythematous ulcerative form of oral lichen planus. As we said before, we have atrophic erythematosus, reticular form, erosion, and papula or plaque form of oral lesion planus. The diagnosis: in order to diagnose this disease, we have to see the history of the patient, the site, appearance of the lesions and their distribution. Papula, reticula, not usually erythematous components have to be present in order to establish the correct clinical diagnosis. And even so, these lesions' appearance could be mixed or appear together with plaque like erythematous bullous or any other ulcerative lesion. And in patient with a gingival erythematous lesion, it is difficult to find stria or papules that will indicate a lesion planus. Therefore, a biopsy is required for more accurate diagnosis of oral lesion planus. Histopathology: after we take the biopsy, we see it on the histopathology. We see an area of hyperkeratosis, a tooth appearance of retipex, liquefactive degeneration, as we said before, with a necrosis of basal cell layer. An eosinophilic band may be seen just beneath the basement membrane containing fibrin covering the lamina propria. A dense subepithelial band tape of lymphocytes and macrophages is also characteristic of the disease. So we have lymphocytes, macrophages, and eosinophils. This is the shape of the oral lesion planus histopathologically. Now let's talk about this oral lesion drug reaction. This one has the same oral characteristics and histopathological characteristics of oral lesion planus, and the patient's history, medical history, will give us an indication of which drug may be involved, that we should ask the patient to withdraw from the drug to see if the lesion drug eruption will resolve or not. But sometimes it's not easy to withdraw necessary drugs. Oral lesion drug, lesion drug eruption can occur with penicillin, gold, non-steroidal anti-inflammatory drugs, sulfonamides. All these drugs could cause lesion drug eruption or lichenoid drug eruption. These lesions, as we said before, have similar characteristics and histopathological appearance to oral lesion planus, but lesion drug reaction are predominantly unilateral and present with ulcerative reaction pattern, as we can see here. Now, after we finished oral lesion planus and oral lichenoid drug eruption, let's talk about lichenoid reaction of graft versus host disease, GVHD. Again, have the same appearance of oral lesion planus lesion, but the lesions are more generalized and appear with other characteristics such as xerostomia and local skin involvement, liver dysfunction, even though that some of the time only oral lichenoid reaction may appear as the only clinical sign of graft versus host disease. Oral lichenoid reaction happens in most of the lichenoid reactions, such as lesion planus, lichenoid drug eruption, and lichenoid reaction of graft versus hosts, and even the one that we will be talking about, lichenoid contact reaction. This one, as we said, is more generalized and happens with correlating diseases like xerostomia and liver dysfunction. The treatment: there is no definitive treatment, and there is no need for treatment if the disease and the action is non-systemic, non-symptomatic. Only typical steroids can be used in severe cases. Ointment on the oral base, that's a topical one, or intralesional injection. For a systemic steroid, a systemic method or a systemic approach, we use systemic steroids in low doses. Again, for typical steroids can be applied on prefabricated plastic trays and applied for the gingiva if it occurs in the gingiva, the graft versus host lichenoid reaction. If it occurs in the gingiva, we apply it for 30 minutes, steroid plastic trays on the gingival tissue. Oral lesion planus, anyone that we've discussed before. Oral lesion planus, actually the specific one that we have discussed before. It's not, we will not talk about the oral lesion reaction, contact reaction, nor the graft versus host one, lichenoid reaction, nor the drug-induced eruption or drug-induced lichenoid reaction. The oral lesion planus is considered to be pre-malignant disorder that increases the risk of malignant transformation of the site of oral mucosa. The patient with oral leaching planus can be a can have a predisposed factor for developing oral carcinoma, although there is very small risk, and it is only 0.2 per year % of the possibility of transformation to a malignant tumor. Now let's talk about the lichenoid contact reaction. This one happens due to the delayed sensitivity or reaction or hypersensitivity to a dental material. Mostly this dental material would be mercury, and lichenoid contact reaction supports the theory that says that lichenoid reactions are an allergic reaction or allergic reactions. Most patients with lichenoid contact reaction will be tested positive for mercury increased levels in the blood. This type of lichenoid reaction, which is oral lichenoid oral contact reaction or lichenoid contact reaction, is similar to oral lichen planus and have ulcerative papular reticular erythematous plaque, or as we know before that oral lichen planus has ulcerative or erosion plaque or papular erythematous or atrophic and reticular forms. And this one is just like the previous one. Oral lichenoid contact reaction, different from oral lichen planus, is that oral lichen contact reactions are confined to a specific site that is in regular contact with a dental material, such as the buccal mucosa, border of the tongue, that are usually in contact with the amalgam filling restoration, just like in this picture. And the majority, and there has been confirmed diagnosis that even composite can cause oral lichenoid contact reaction, even composite material, not only amalgam. And this lichenoid reaction can be eliminated using treatment of the medication called chlorhexidine, and the direct removal of this material that is offending to the oral mucosa can cause a relief and a treatment in more than 90% of cases. Now let's talk about the lupus erythematosus. That is a connective tissue disease that has two main forms. First one is the systemic, and the second is the discoid lupus erythematosus. Both of these can give rise to a similar lesion to oral lichen planus. The systemic lupus have more effects than the discoid type of lupus, including arthralgias and rashes, but any organ can be affected. And arthralgia, by the way, from its name, arthro that's joints, algia that's pain in the joints, or arthritis. In the disease of lupus erythematosus, we have a variety of antibodies that are presented, particularly anti-nuclear that is produced. And the discoid lupus is essentially a skin disease with a mucocutaneous lesions that is indistinguishable from the systemic lupus erythematosus. Also can be happened with arthralgia and a significant antibody production. Significant antibody production is rare in discoid lupus, but it is more common in systemic lupus. Only 20% of systemic lupus will include the oral cavity, and its shape is white stria of lesion that are less sharply defined than the lichen planus, oral lichen planus, and could appear even in the vault of the palate, which is not usually happened with oral lichen planus. So in oral lichen planus, it was mainly on the dorsum of the tongue, buccal mucosa, but here it could even affect the palate in the systemic or discoid lupus erythematosus. A slit-like ulcer short of the gingival margin could appear in 30% of cases, and as Sjogren syndrome can develop even though it is rarely develops. Sjogren's syndrome. And the cervical lymphadenopathy is a first sign to see in systemic lupus. Systemic and discoid lupus are both appear the same orally, and even after histopathological examination or clinical examination, they appear the same. A well-demarcated cutaneous lesion with round or oval erythematous plaques. And these lesions may appear as a butterfly-like rash over the cheeks and nose, called malar rash. As you can see in this picture, malar rash with lupus erythematosus, discoid or systemic, and this one is on the belly, this one is then on the buccal mucosa, on the tongue, etc. As we said before, there is an increase in the anti-nuclear antibodies. These anti-nuclear antibodies are an indication of systemic lupus when we want to have a diagnostic of systemic lupus erythematosus. More investigation is needed, as if we want to see the blood test, we will notice a raised in erythrocyte sedimentation rate, anemia, and often leukopenia and thrombocytopenia in systemic lupus erythematosus. If we want to treat discoid lupus, we will introduce topical corticosteroids. However, these corticosteroids or steroids will not be helpful in systemic lupus erythematosus, and under such circumstances we give systemic lupus systemic corticosteroids, and there is no effect on the systemic lupus erythematosus, only affects the discoid lupus erythematosus. Therefore, we will have to go to the palliative treatment until the disease activity is decreased. Now moving to ulcerations with preceding vesicularization, or that ulcerations that are preceded by vesicularization. We talked about just now vesiculations that were not preceded by vesiculations, non-infective stomatitis. These were Behçet's disease, systemic and discoid lupus, lichenoid reactions, and now we will talk about the non-infective stomatitis that are not preceded by vesiculations. Only one type we'll talk about, pemphigus, but pemphigus have many types. It is uncommon disease causing vesicles or bullae on the skin and mucous membrane. It's usually fatal if untreated. Therefore, we have to be careful with it. Females from 40 to 60 years of age are predominantly affected, and the lesion is first appearing on the mouth but spread widely on the skin. This is a very important thing to notice. It first appears on the mouth. That's why we have to deal with it and know and diagnose it before it goes and appears on the skin. The vesicle is fragile and infrequently seen intact in the mouth. Residual erosions often have ragged edges and are superficial, painful, and tender. Gently stroking the mucosa can cause vesicle or bulla to appear. This is very important. Gently stroking the mucosa can cause the vesicle or bulla to appear even in a healthy skin. When you stroke the skin, there is a Nikolsky's sign, and this sign is very important to notice. Several types of the pemphigus, as I said. Pemphigus vulgaris is the most common, then pemphigus vegetans is a variant of pemphigus vulgaris, and both of them affect the oral mucosa. Then pemphigus foliaceus, pemphigus erythematosus, that's a variant of pemphigus foliaceus. Then lastly, we will talk about paraneoplastic pemphigus, and there are even more types that we will talk about later. Starting with pemphigus vulgaris. On 80% of all pemphigus cases is the vulgaris type. Underlying mechanism, how and etiology of how this disease is formed is when the intraepithelial lesion of pemphigus vulgaris is binding the IgG antibody or an autoantibodies to DSG3, that's a transmembrane glycoprotein adhesion molecular present on the desmosome. So there is something happening with the desmosome on the corneum. It is not affected, but we're talking about spinosome, granulosome, and basal. There is something going on there causing the pemphigus vulgaris. Sometimes the disease is fulminating with rapid development. That's why it's variant. Sometimes it's less serious, less severe, and it's mostly developing first on the oral cavity, spreading to the eyes within a few days, and very soon appearing on the skin, consisting on the skin of shape of bollas, vesicles, varying from millimeters to centimeters. And the bullae first containing clear fluid, then they become purulent with hemorrhage. And a rupture of the bullae or the vesicle leaves a painful, ragged erosion. The protein, fluids, and electrolytes are lost from the area and they rapidly become secondary infected. Without treatment, death usually follows. That's why we would need immunosuppressive drugs systemically to treat such disease, and they are life-saving in this case. As I said, females are more affected. In pemphigus vulgaris, lesions first appear in the mouth, and in 90 to 80% of patients develop oral lesion during the course of the disease, and 60% of cases the oral lesions are most of the time the first sign of the pemphigus vulgaris. It's common in the oral lesion to present for months before the skin lesion appears. This information is very important. Not sometimes within a few days from mouth transferring to the skin, the lesion, and sometimes from mouth to the lesion it takes about 1 or a few months before it appears on the skin. The lesion consists of fragile vesicles or bullae, ruptured vesicles from irregular erosion of the mucosa. And Nikolsky sign is a positive sign of this disease and a characteristic of it. And to assess Nikolsky sign, we have to apply pressure to an intact bullae in patient with pemphigus vulgaris, and the bullae will enlarge or extend to an apparently normal surface. Another characteristic of this disease is even when applying a pressure on apparently normal area, this would result in a formation of a new lesion, and this phenomenon is called, as usual, Nikolsky sign. So if we apply pressure on a normal healthy area or apply it on the bullae, there will be enlargement and bullae formation, and etc. That's a Nikolsky sign. In severe cases, conjunctival, pharyngeal, and laryngeal mucosa can be infected as long as with the skin lesions, and this could be fatal. They have good response to immunosuppressive treatment. As we can see, this is probably untreated pemphigus vulgaris on the oral mucosa. Very important to do diagnosis as early as possible because we don't want this pemphigus vulgaris to be spread from the oral mucosa to the skin. And a biopsy is essential. Even a biopsy with immunofluorescence microscopy should be used in order to distinguish the lesion from other less common diseases. And as we can see, this is the immunofluorescence microscopic diagnosis. Once the diagnosis has been confirmed, then we go to the immunosuppressive treatment, although there is no consensus of what is the doses recommended, but an 80 to 100 milligram per day of prednisolone plus azathioprine, 1 to 1.5 milligram per kilogram is recommended for azathioprine and prednisolone and azathioprine. Azathioprine is given to allow the doses of corticosteroid, in this case prednisolone, to be lowered and reduce their side effects. And the treatment can only be stopped after the relapse fail in case of withdrawal of immunosuppressive treatment. That's why if we withdraw immunosuppressive drugs, we would have to see no relapse. Therefore, we can stop the treatment. But in this case, even treatment itself can cause mortality, as immunosuppression can cause other diseases, and the mortality rate, even with treatment, is still 6% death mortality. Again, these drugs are important: prednisolone and azathioprine. Paraneoplastic pemphigus. Now let's read about this. It's a severe blistering disease that is a multi-organ disease associated with underlying neoplasm, most frequently non-Hodgkin lymphoma and chronic lymphatic leukemia or thymoma. Again, it's a multi-organ disease and with neoplasm such as non-Hodgkin lymphoma, chronic lymphatic leukemia, or thymoma. It is also referred to as paraneoplastic, not paraneoplastic pemphigus. This one is the first name that we know, but it's also referred to as paraneoplastic autoimmune multi-organ syndrome because of the involvement of other systems such as lungs in particular. So paraneoplastic pemphigus, referred to as paraneoplastic autoimmune multi-organ syndrome, involving the lungs sometimes. It is followed by or coexistent with underlying neoplasms such as the ones that we mentioned before: non-Hodgkin lymphoma, chronic lymphocytic leukemia, or thymoma. And this is a picture for it. After we talked about non-infective stomatitis with a preceding vesiculation without a preceding vesiculation, that were the Badger disease, lichenoid reaction, and lupus erythematosus. And we also talked about non-infective stomatitis with preceding vesiculations like pemphigus vulgaris and paraneoplastic pemphigus. These were types of pemphigus. Now let's talk about also non-infective stomatitis with preceding vesiculations, but this time it is non-pemphigus. It is subepithelia bullous dermatosis type, some of which like pemphigoid or bullous pemphigoid, and the others maybe like this one, mucous membrane pemphigoid. Both are type of subepithelia bullous dermatosis. So mucous membrane pemphigoid is uncommon chronic disease causing bullae and painful erosions. Skin involvement is uncommon and often trivial. The term cicatricial pemphigoid, mucous membrane pemphigoid, is sometimes used for this group of diseases, but particularly applies to ocular involvement where scarring is prominent and impairs sight. Lesions are rarely widespread and progress is slow. Desquamative gingivitis can be manifestation. Unlike pemphigus vulgaris, spread is slow and rare, although we have desquamative gingivitis can occur. Nikolowski's sign, as you remember with pemphigus vulgaris, is here also positive, and a striking clinical finding sometimes that when the epithelium slides away underneath the edge of a sharp scalpel when a biopsy is attempted. And this is very striking and weird incidents happening with mucous membrane pemphigoid, which is a type of subepithelial bullous dermatosis. Subepithelial bullous dermatosis. And this striking clinical finding is happening in the mouth. Also, Nikolowski sign can appear. Rupture of erosions leaves raw areas with well-defined margins. Individual erosions persist for some weeks to a year or more. Lesions may remain localized to the mouth for very long periods and may never involve other sites. So mucous membrane pemphigoid can only happen on the mouth. Females mainly affected and usually elderly females. And this is a typical feature. Mucous membrane pemphigoid. Oral mucosa, often the first site of lesion, and may involve mucosal surface, but the oral mucosa is involved in more than 80% of cases, rarely with scarring. So other mucosal type can involved, but mostly oral mucosa with 80%. Involving of eyes may cause scarring and blindness. The conjunctiva is the second most common site of involvement after the mouth and can lead to scarring and adhesions developing between the bulbar and palpebral conjunctiva called symblyvaron. Skin involvement is absent or minimal. Although it is called mucous membrane pemphigoid, mucus is only limited to mucous membrane of the mouth. Skin is not involved and other mucous tissue is not involved. Sometimes it's in the eye. The lesion or the disease is indolent, non-fatal disease. Indolent, that means it's lazy. Oral bullae are subepithelial and frequently seen intact, as this picture and this picture and this one, of course, involving the eyes. Mucous membrane pemphigoid. It is very important to notice that this disease is carrying an underlying association with malignancy. Therefore, the clinician should consider referral to rule out any possible underlying malignancy in a newly diagnosed mucous membrane pemphigoid patients. A biopsy is performed, and this is used to rule out any possible malignancy. Drugs such as clodine, dipencylamine, and L-DOPA have been reported as regulating factor for mucous membrane pemphigoid and the mucous membrane pemphigoid triggers are also important because mucous membrane pemphigoid is associated with malignancy. Management diagnosis is confirmed by biopsy and immunofluorescence microscopy, but it is preferable to obtain an intact vesicle or bulla. Other mucous membrane pemphigoid can often be effectively controlled with topical corticosteroids. Doses are small and without systemic effects because of the possible risk of site ocular examination. Possible risk to site ocular examination is necessary if early changes in the eyes are suspected. Therefore, we have to refer the patient to the ophthalmologist. If the eyes become involved, systemic corticosteroids have to be given and are effective. So we don't usually just give systemic or corticosteroids. First of all, we have to see if the eye is involved or not. If it's not involved, we just give oral topical immunosuppressive corticosteroids. And by the way, if we go and refer the patient to the ophthalmologist, that's okay if an optometrist sees the patient or even an optician sees the patient. So we have an optician, ophthalmologists, and optometrist. All of those can see the patient and determine the patient's condition, eye condition, and if there is a mucous membrane pemphigoid happening with it. The sequelative gingivitis can often be managed with topical steroid in a soft dental splint that covers the gingiva. Although the clinician using topical steroids over large areas of mucosa must closely monitor the patients for side effects such as candidiasis and effect of systemic absorption. So if we give the patient these topical steroids, if it's involved a large area to treat the mucous membrane pemphigoid, this way we have to be measuring the patients for any candidial infection or systemic absorption, because systemic absorption is not healthy for the patient to be suppressing his immune response entirely. Now let's move on to another type of subepithelial bullous dermatosis. Of course, we talked about before the pemphigus vulgaris, the pemphigus type, but now we are talking about subepithelial blister or bullous disease or dermatosis. And this is very common. Actually, it is the most common type of subepithelial blistering disease. Is called the bullous pemphigoid. And this one occurs chiefly in adults over the 60 years of age, self-limiting and may last from a few months to 5 years. Pemphigus bullous may be a cause of death in older debilitated individuals, and bullous pemphigoid has occasionally been reported in conjunction with other diseases, particularly multiple sclerosis, malignancy, and drug therapy, particularly diuretics. Again, malignancy, multiple sclerosis, diuretics. Pemphigoid bullous is an autoimmune disease caused by the binding of autoantibodies to specific antigens found in the lamina lucida region of the basement membrane on the hemidesmosome of epithelial basal cells. Clinical manifestations, the characteristic skin lesion of bullous pemphigoid is a tense blister on an inflamed space or inflamed base. Tense blister on inflamed base accompanied by urticaria, plaques that chiefly involve the scalp, abdomen, extremities, axilla, and grillon. And by the way, grillon is the area between the stomach and the thigh in both sides of the body. Pruritus is a common feature of the skin lesion, which may initially present. The disease is self-limiting but can last for months to years without therapy. Usually pemphigus bullous pemphigoid, unlike pemphigus bullous pemphigoid, is not life-threatening since the bullae do not continue to extend at the periphery to form large denuded area. And in this picture we can see it. Oral involvement only 10 to 20% pemphigoid, unlike mucous membrane pemphigoid. The bullous pemphigoid is only 20 to 10% evolving involving the oral cavity. Oral lesions of bullous pemphigoid are similar, form more slowly and are less painful than those seen in pemphigoid vulgaris. The often extensive labial involvement seen in pemphigoid vulgaris is not present. The squamative gingivitis has also been reported as the most common oral manifestation of bullous pemphigoid, and the gingival lesions may be the only site of oral involvement. The gingival lesions consist of generalized edema, inflammation, and desquamation with localized areas of desecrate vesicle formation. So it's only involving the gingiva with desquamation, with vesicle formation. The oral lesions are clinically and histologically indistinguishable from the oral lesions of the mucous membrane pemphigoid, but early remission of bullous pemphigoid is more common. So remission of bullous pemphigoid is more common than mucous membrane pemphigoid remission. And this is the mucous membrane. This is the bullous pemphigoid. Management: patients with localized oral lesions of bullous pemphigoid may be treated with high potency topical steroids such as clobetasol. And this is only for localized infection of bullous pemphigoid. But we will treat them with clobetasol, or this is a topical steroid, by the way, topical corticosteroid, betamethasone. But in case of more extensive disease generally affecting the body, that would require a systemic corticosteroids, even alone systemic corticosteroids, or in combination with immunosuppressive drugs. Immunosuppressive drug usually, as we mentioned before, azathioprine, cyclophosphamide, mycophenolate, or rituximab. Patients with moderate level of disease, not large, not small and local, those would minimize the use of systemic steroids by only using dapsone, tetracycline, doxycycline, minocycline, and those can be used in combination with niacinamide. Thank you for listening to this lecture. It was a very important lecture with the pemphigus. We talked about many things: lichen planus, disease, non-infective stomatitis. There are still more lectures to come. Maybe we will talk about infective stomatitis and many types of infective stomatitis. Thank you for listening.